Mr. Arun, 26-year-old male patient from Tirunelveli, who is a manual laborer by occupation, came with chief complaints of swelling over outer margin of right eye for the past 4 years. No history of constitutional symptoms. Local examination, proper consent was taken. Patient was examined in a well-lit room in sitting position and myself standing in front of the patient. Inspection, a single swelling is present on the outer canthus of eye with lateral edge of eyebrows over the swelling. With size 4 into 4 centimeter, hemispherical in shape and smooth surface, well-defined margin, skin over the swelling is normal, no signs of inflammation and no punctum over the surface of the swelling. Palpation, all inspectory findings are confirmed by palpation. No local warmth, no tender, smooth and well-defined margins, smooth surface, soft in consistency, skin over the swelling is pinchable and no bony indentation felt. Plane of the swelling is subcutaneous. Mobility, mobile on both sides.
Have you ever read any books giving inspectory findings? No, I'm not from Western people's school or anything, but not very widely heard. Inspection findings are counted. That is it. Inspectory, ma'am, is there any term like that? I don't know, because undergraduates need not be taught wrong English. So inspection findings. Another thing is, you rightly said all those under inspection confirmed is a very easy way of summing it. We fully agree with you. Yes.
Fluctuation is positive, translumination is negative, not compressible, not reducible, no cuff impulse, and regional lymph nodes is not palpable. Some consistency, soft inconsistency.
Now you haven't included in that. Do you think it is important or not?
Yes,
necessarily.
Yes, important. Included.
Hey, where is it? In under palpation. Okay. Soft.
Why you look for fluctuation and transformation in a soft swelling?
For the content.
Cystic or non-cystic? In cystic swelling only you have to look for fluctuation and transformation. Because you have mentioned transformation and insult. Whether it was cystic or non-cystic.
But there is a clarification required there. I think I may not be teaching anybody else other than my students, please, but things have to be very clear. Journals are writing soft and cystic, but for undergraduate's purpose, you should tell soft as consistency or firm or hard, but the cystic is always an inference, not a finding. So it's better that you say fluctuation test in a big significant swelling. Fluctuation positive and soft, we will get an inference that it is a cystic swelling. But if you get a dilemma in a small swelling, you must have replaced fluctuation test by pages. Soft, when you say fluctuation positive, an inference is cystic. Though some journals, some articles still write there is cystic, this thing called. But as per Das teaching, internationally renowned, he said, it's still better to say finding palpation as fluctuation test and pages. So it is as they rightly asked about soft consistency with a fluctuation positive. I am more than happy to get that the inference is cystic. That's the way you are supposed to say. Yes.
Summary, a 26-year-old male patient came with chief complaints of swelling on the outer canthus of the right eye for the past 4 years. On examination, a swelling is present in the outer angle of right orbit of size 4 into 4 centimeter, hemispherical in shape, soft in consistency, well-defined margin, smooth surface, moving freely in both axes. Skin of the swelling is pinchable and fluctuation test is positive. Diagnosis.
Before that, I think there should be some clinics taking place by this all arrangements, getting some faculty from elsewhere, etc. So surface you have said, because I just want to propagate the message of easy learning, that's why I am just probing into questions. You have a surface, we said the surface may be classed into smooth and irregular. Is there any further division of the surfaces? This is your undergraduate question I am asking.
Lobulated.
Some people say lobulated, some people say what else? Bosilated, some people say nodular, some people say still some more option, granular. There is also a granular. To put it into all those dilemmas into well-fitting, I had a great teacher. So again, I quote teachers than books sometimes. Books, all of you know, non-books. My internal exam for PG, Professor Premendra sir used to teach, Professor Raghavajari sir. He is a great name. We have still an oration in the state ASA meet. Always, every year there is a Professor Raghavajari sir. Such a great teacher of Government Medical College, Trivandrum. So sir, this teaching you will not get in textbooks, that's why, but it's very simple. So Premendra sir used to teach us, the surface is divided into smooth and irregular. The irregularity is further divided into fine irregularity, moderate irregularity, gross irregularity. Why I say this is because there is a confusion recently regarding bosilated in some textbooks. So, but that is not bosillation. Bosillation will be clarified in my statement. So, fine irregularity is otherwise named as a granular field. The typical example of such a granular field is you palpate the omentocele. It is a granular field. You palpate the upper outer quadrant of a premenstrually engorged breast of a patient having fibroadenosis known. There the upper outer quadrant is granular, something like our sago seed or rice seed. That is a typicizing example of the surface. I am just telling it to compare it with surface irregular everywhere, how to put it. You need not tell it as granular, at least you must tell it as, sir, it is finely irregular. That is okay. Now, the moderately irregular surface is otherwise named as nodular. The typical example of a nodular surface is multinodular goiter. Of an organ, typical example is a secondary liver or a cirrhotic liver. The difference between a secondary liver and a cirrhotic liver is the presence or absence of the umbilical. That's all. And this is medicine teaching. So we have typicized it as moderate irregularity. Typical examples are nodular, and the nodularity is examples we said. Then we get the extreme extent of irregularity, as we say hillocks and valley field. Raised, big one, another gap, then a big one, like that. And that is typically described as the bosilated. And to my plea, I must stress that bosilated is a characteristic to be applied only for gross irregularity of a surface. Typical examples of that is usually a multiple cyst-rich organ like a polycystic kidney. Typically described as polycystic kidney, but some people also add multicystic diseases when palpable of the organ. So polycystic organ, typically of kidney or of liver, can be better described as a bosilated surface. That's how the surface. So there is no confusion whatsoever. If you know this, surface is fine, smooth or irregular. Irregular is either fine irregularity, moderate irregularity, gross irregularity. Fine is otherwise named as granular. Some add that is lobulated as a typical example of fine irregularity. So a lipoma also is settled. Surface may be finely irregular. Moderate is actually either multinodular goiter or cirrhotic liver or secondary liver. And the gross irregularity is classed under. That's a great teaching which may not be printed in books, but it is very helpful having no biased opinion about a surface. Okay. Yes, proceed. Now, what is the diagnosis?
It is a case of benign swelling, probably dermoid cyst over the outer canthus of eye, sequestration type. Investigation, X-ray skull, AP and lateral view, CT head.
Can you be a little more specific in your diagnosis? Simply a dermoid cyst, or you want to give some qualification?
External angular.
It should have a prefix of external angular. Because simple dermoids are widely described in the midline. This is a little away from that. Yes, proceed.
To rule out any intracranial extension. No bone intimation. It is.
The ultimate of head, you can write like CT, brain, or facial bones, like that you have to mention. Don't write head like that. Okay. Yeah, we are doctors now.
FNAC, USD, then
You will do an USC of an external angular dermoid. If at all, okay, I agree with you. If at all, if you do an US, what is the inference which you are going to get?
condensed
You can get if at all the condensed comment only.
then general investigation.
Why do you want to do FNAC? When you are clear about a diagnosis, do you get anything extra by doing FNAC in this case? Unnecessarily patient. So,
CBC, hemoglobin percentage, bleeding time, clotting time, ESR, blood sugar, urine albumin, sugar, and ECG. And treatment.
routine investigation madam, general routine specific
Today morning, I think I was mentioning about the pattern of mentioning in short case and long case doesn't matter. Now, when you say investigation, the investigation to know assess the operability of the patient. That means the general evaluation is. Then investigation specific to confirm or to exclude our clinical diagnosis. That is the way you should suppose. Then you go to the treatment that will be totally covering the term management. That is how you should do.
Treatment is excisional biopsy.
Yeah. Anesthesia. Yeah.
Local anesthesia.
Why? Yeah. Always you opt for local or you will consult with the patient. You will have counseling of the patient and the relatives if they opt. You can even use cheers, especially when there is a long-standing, scalloping, eroding, etc. of the bone possible, etc. You want to take it under local, may not be very painless, and that case you can do this.
It is a cyst due to sequestration of epithelium into the deeper layer of cells.
Epithelium, total, isn't it? That's what you mean, isn't it? What's the difference between a sebaceous cyst and a dermoid cyst under the microscope?
In sebaceous cyst, the skin is not pinchable, whereas in dermoid it is pinchable.
I was asking under the microscope. That is clinical. I agree with you. Skin cannot be pinched. Skin cannot be pinched, at least at its summit. In sebaceous cyst, there may be a punctum, etc. But dermoid cyst, under the microscope.
Stratified squamous epithelium is present in dermoid.
So there is a better term. The pathologists report it as epidermoid cyst. That is an epidermal element. Dermoid cyst, you may have epidermis as well as constituents of the dermis. That's why it is better named. Clinically, the content is also described by two. What is a typical description?
Dermoid, it is pultaceous material.
Pultaceous or pultaceous, both are correct pronunciation. Yes, then
In
sebaceous cyst.
cheesy white appearance material.
Sorry?
Grayish white appearance.
And its smell is actually little
Foul smelling.
So, one is pultaceous, one is putty like. That is a description. So then next, what else?
Stopping here, but you best learn about the differential diagnosis. How will you differentiate?
Sure.
What is the difference between compressibility and reducibility? What is compressibility? What is reducibility?
Yeah, they were asking from the very beginning compressibility and reducibility.
A swelling is said to be compressible if it doesn't completely disappear. It reappears when the pressure is released. But reducibility, the swelling completely disappears and it doesn't reappear unless an opposite force acts on it.
The right answer. But only thing is, unless there is an effort from the part of the patient or change of posture.
Like
It needs some effort on
From
the part of the patient for the swelling to reappear.
For that matter of fact, I would like to combine it with an impulse of coughing also. What is an impulse on coughing? So because this is a discussion of the swelling, we need to clarify something related to swelling examination. What is compressibility, what is reducibility, we have already said. So that is right answer. What is an impulse on coughing?
Whenever there is an connection with the any cavity, there will be impulse on
That's
coughing.
not the definition. That's not the description. I am not very particular about the particular word used in this, but describe. So there is a beautiful description I just want to teach my entire UG students. PG, our others, they already know. Appearance of a swelling at a site where it was not present, or increase in size of a swelling which is already present at a site upon exertion from the part of the patient. That is a definition. That's complete, pakka complete definition. And what is this upon exertion? Upon exertion is for a baby it is crying. Or for an adult it is cough impulse, or at particular site doing Valsalva's manner. This is that. So if there is impulse on coughing, it may be reducible unless complicated. And that explains the reducibility. And the patient needs an effort from their side if it is communicating with that to reappear. It may not be always for a limb swelling which can be compressed and disappears, maybe something related to vessel or lymphatic etc. Maybe by change of posture even, it may by time it may allow. Then what is the difference? What do you correlate with molding also? Ma'am was asking molding etc. What is the difference between molding and compressibility?
Here the content is not completely displaced into the cavity in the molding. It
That
just takes up the
that
shape
you are
of the
explaining
patient.
it, but you must say that in molding only the shape is altered, but the size is not, remains unaltered. That is the right answer. So size is never altered, but only shape. Whereas in reducibility, compressibility, etc., the size is also altered. That's how. This is basic surgical teaching. I think that you should be taught at the UG level itself.
So just because I said go to the exam and appear very confidently doesn't mean that don't read and look only confident. Okay, you study well and appear confident. Don't go without studying and appear confident. Okay, nicely presented, ma'am.
Yeah. You have done responsive.